speaker today is Dr. Sue Peters. She's an assistant professor in the School of Physical Therapy at Western University in Ontario, Canada. And Dr. Peters is a physical therapist by training and has a PhD in rehabilitation sciences and neurophysiology. And I'm passing the floor to Dr. Peters. Thank you, Dr. Peters, for coming to this event and speaking about your research. Welcome.
Great. Thank you so much. I am thrilled to be here. Can I just check that the audio is coming through okay?
I
You can
hear
hear me?
you.
Okay, wonderful. Great. So the title of this talk is based on the paper that we recently published as a team, Safety and Effectiveness of the Walk and Watch Structured Progressive Exercise Protocol, delivered by physical therapists for inpatient stroke rehabilitation in Canada, the Phase 3 multisite pragmatic step-wedge cluster randomized control trial. So I always get a little bit of a chuckle saying the whole title. I keep thinking we must get a prize for the longest title in the history of this particular journal. I haven't gotten any notification yet, but it was through the peer review process that the title kept getting longer and longer and longer. So as a team, and when we do presentations, we often just describe it shortly as the Walk and Watch trial. So here we go. There, let me advance my screen. So before I dive into the details, I do want to let you know about the funding related to the trial. So we did have multiple sources of funding and listed here. And I also really want to acknowledge all the hospitals that were involved. We had 12 sites across Canada, and they're listed here in this bullet point. Really, this could not have happened without the physical therapists, the rehabilitation assistants, the unit managers, with their full support and really embracing this research project. So I have two main objectives for us today. And the first is to tell you about the background and the results of the Walk and Watch trial. There was also a recent publication where we described the experiences of the Walk and Watch therapists. We did some surveys and interviews of the therapists that were actually involved in delivering the protocol. And so I'd like to share with you some of their thoughts and experiences with using it as well. So I know that most of us here are very busy clinicians, and so I often like to start my talks with telling you what the take-home points are. So that way, if you need to leave early, you already got something out of the talk. And so for those individuals who received the Walk and Watch protocol, they walked on average 44 more meters on the 6-minute walk test at discharge from inpatient stroke rehab compared with those in usual care. The therapists who delivered the Walk and Watch felt the protocol helped them translate best practice into actual clinical applications. They did say the timing and staffing was hard because the sessions were potentially a little bit longer than what some of these units were used to, and especially if they had to juggle multiple priorities, which often happens in the real world. We did have nursing, OTs, rehab assistants, family members that ended up being involved in delivering the protocol. Doctors were always involved. So let's dive into some of the background. So I was also peripherally involved in the DOSE trial, which was published in the journal Stroke in 2020. And with that particular DOSE trial, we found that high repetitions of walking during the subacute stroke period improved walking recovery and quality of life. But in reality, and having worked myself as a frontline physical therapist, I know that it's really hard to actually do this in clinical practice. Walking is not the only rehab goal for most of our patients. Patients have high levels of fatigue that you need to manage constantly, and staffing can be challenging to organize for patients who need two-person assist, especially if you want to increase the repetition or the challenge of walking practice. So what our goal is to enable entire stroke units to use the Walk and Watch protocol to determine its effectiveness on the 6-minute walk test, which was our primary outcome, and to really do this in more of a real world setting than more of a research-based setting. A key aspect of this trial is that frontline clinicians delivered our Walk and Watch protocol as part of their usual care. So our protocol, in a nutshell, was greater than or equal to 30 minutes of weight-bearing walking-related activities that progressively increased in intensity informed by activity trackers. And I'll tell you a lot more about what the protocol details were in the next few slides. So the overall aim of the study, which was in the publication, is to determine the effect on the primary outcome of walking after stroke over that inpatient rehab period. We had some primary and secondary outcomes. So I've already described the 6-minute walk test. And here we were looking at the change in the walking endurance, the distance obtained on the 6-minute walk test from a baseline measure, so at admission to the inpatient stroke unit, to when they were discharged 4 weeks later. So looking at the difference in that measure. And we compared usual care to walk and watch phases in our trial. We did have secondary outcomes as well, and those included physical, cognitive, and quality of life outcomes. So we did have 12 sites across 7 provinces. And I want to note that 7 of these sites were smaller cities with a large rural catchment area. So if you know anything about Canada, is we have a lot of rural parts of Canada. Anything urban is really close to the border, but a lot of it is rural. And so it was really important for us to have that blend of rural and urban areas to ensure that we captured a very diverse population within this study. So the stars here do highlight the locations of those cities that were involved. Also to note that we did select sites that weren't typically invited to participate in clinical trials. That was another real world aspect of this study, is that often when you do research, you think of like, what are the sites that we've used in the past that are enabled and already have a coordinator, research assistants, and so on that are trained. But here, because we wanted that real world aspect of this trial, we invited some sites that didn't have those sort of resources in place at the beginning, and we trained each site to do these on their own. So we did do a step-wedge cluster randomized control trial. So I do like to spend a little bit of time talking about what this is, because it's an important aspect of the study, and it's a relatively new trial design, especially for a lot of the excuse me, frontline clinicians that I speak with. And so here we have units that are randomized to different sequences. And each sequence represents a different time of switch from usual care to walk and watch. So in this particular image, all of the green blocks indicate the length of time that we're collecting usual care. There was a brief 2-week transition period where we would do training, a washout period for any participants that had started usual care that they would complete. And then we would have folks switch over to walk and watch in the blue time here. So of note is that all sites started in phase 1, which was usual care, and then they were randomized to when they flipped over. So you'll note that some sites then would collect data in usual care for quite a long time, almost the whole trial period, with only the last part of the study flipping to walk and watch. So for example, if your site was in sequence B, you would have collected usual care for 8 months, had a 2-week washout period, and then 12 months of the walk and watch data collection intervention period. So another thing to note is our assessors were blinded, which is again a good design protocol for clinical trials. And patients consented to receiving outcome measures because once the sites received the training in the walk and watch, then that became part of usual care. And so patients didn't need to consent to the walk and watch intervention itself, but they consented to the collection of outcome measures around the intervention. So here's our inclusion and exclusion criteria. And so we included people who were adults who were admitted for inpatient stroke rehab where walking was a goal. So for example, someone admitted where their primary impairments are cognitive and upper extremity, they wouldn't have been invited to participate. We did have a relatively large window of time that we allowed people to be invited to participate. So within 12 weeks of rehab admission. We chose that because we still wanted them to be within that early subacute phase, but to allow for a broad inclusion criteria, again, because we wanted it to be more real world and more applicable, more broadly applicable after the trial was done. They needed to be medically stable, which most of our patients are when they get to a rehab setting. And they needed to be able to walk 5 steps with a maximum of 1 person helping or 1 person assist, able to understand and follow instructions. If they had any other neurological condition, another rehab study, or if they were in inpatients for less than 2 weeks, then we did exclude them in this particular study. So I do note that there's a reference here at the bottom, and that is the protocol paper that was published. So that's the citation there if you would like that to look up. So what is the protocol? And so I do want to note that we had frontline therapists after the training that we gave them. They did these 3 steps of the protocol. So they did a screening component, which is what this is. So they first checked for eligibility. So similar to what I just went through there, we had them do a quick check to see did they meet eligibility, and if so, they did a screen for safety. And that's the next step. So there was a few steps to completing a safety screen. So part of it is a chart screen, which is again a normal part of our clinical practice before you go and mobilize someone. We did have a list, like this bullet point list of medical conditions that if you saw these in the chart, that it was not a red flag as in don't do walk and watch with this patient. It was more of a flag to talk to the unit physician or the patient's physiatrist or whoever was the responsible doctor for that patient, and just have a conversation with them. So for example, someone who had a higher resting heart rate than 120 beats per minute, that just warranted a conversation with the medical doctor that perhaps they still felt it was safe to do higher intensity walking practice with this patient. We did develop this list in consultation with the physiatrists that are part of the study team, which is how we ended up with this list. So they also did a resting heart rate and blood pressure screen or check. So often it was the therapist checking the chart notes, looking at the nurse's notes to see was their heart rate within the last few hours, was it relatively stable, and was it below these cutoffs? And then if so, then they were also safe to proceed. The final component of the safety screen was to complete a 6-minute walk test. And I'm not sure if that's part of your regular clinical practice in your settings, but here in Canada, most sites would do a 6-minute walk test with our patients on admission and discharge. So this wasn't a big ask of our frontline therapists as it was already embedded in what they were typically doing. The difference was that we were asking them to complete some paperwork related to that, just to have a little bit more of a definitive guide for them as to what constituted a pass and what constituted a fail. So fail, again, didn't mean that they would never receive walk and watch. A fail meant during the 6-minute walk test, perhaps they developed some angina, and that just meant, again, a conversation with their physician to see whether it was safe for them to proceed to higher intensity walking practice. So the third part was to deliver the walk and watch protocol. And so here the protocol states to start with a minimum of 30 consecutive minutes of weight-bearing gait-related activities. And so this was a bit of a paradigm shift for a lot of our therapists where, and me included, like you also often start with the pre-gait activities and then you go into gait type of activities. So here we were asking therapists to almost like save pre-gait for post-gait activities. To just go right up into standing and stepping practice. We did have them monitor targets with step counters and heart rate monitors. We provided a heart rate target of 40 to 60% of heart rate reserve. And so this is a minimally aerobic level of heart rate reserve. So we're not asking them to go very high intensity. It's enough for them to get a little bit out of breath, but not enough for them to really reach that high aerobic intensity activity. In addition to the heart rate targets, we provided the step targets. So in this table here, we provided targets based on the distance they walked on the 6-minute walk test. And so if they walked 100 meters or less, at the end of week 1, we wanted them to aim for about 1,000 steps per session. By the end of the second week, aiming for 1,500, and by the end of 4 weeks, aiming for 2,000. So from there, we gave targets that were progressively increasing and more challenging based on their initial baseline function, which would have meant that our high functioning folks right at the beginning would have been doing quite a bit more activity right off the bat and then increasing from there. So we didn't pull these numbers out of a hat. I used data from the dose trials, that earlier pilot trial that we used to model off of the walk and watch. And from those data, we modeled these numbers and then provided these as guidance for our therapists. So we also provided equipment to the units. And so we provided a Garmin heart rate monitor, so it's wrist-based, the Fitbit, the Fitbit Inspire, which is shown here. And we had it attached to the ankle to monitor and count the number of steps. And again, we just didn't decide to do this. We based this off of previous research done within the group. And so they measured whether to put it at the waist or the ankle, and putting it at the non-predic ankle was the most accurate way to count steps, especially in our slower walking folks, where they don't necessarily step as quickly as other people do. And so what was unique about this trial is we didn't tell the therapists what tasks to do, except that it needed to be standing and weight bearing. And I think to me that was one of the things that I thought was a strength of this trial, is that the therapist could tailor the protocol to the patient in front of them and really individualize and make it relevant for their particular goals. And so they did a variety of functional tasks. And here are some examples. They used their clinical judgment to determine what was most appropriate, and they were measuring the heart rate and the number of steps as they were doing it. So we did provide a bank of examples. We went through some case studies in the training, but beyond that, they took it from there. We did provide units with a weighted vest and cuff weights to help increase heart rate. And even adding a few pounds, like this particular device here, I think was 6 or 7 pounds. But we provide it had the adjustable weight, so you could add more or less weight. So you could stick something in the back here if you wanted to make it a little bit heavier. And we found that even just adding a couple of pounds to our participants, even if they were walking quite slowly, it was enough to increase the heart rate and help reach some of those targets. And, most units have those cuff weights anyway. So an easy way to increase heart rate. So what do we find? So we started data collection in 2021. And as probably you remember, that was shortly after COVID. And so we did have to deal with some of those type of impacts with the trial. We did end up completing the primary outcome in 2024. So I do want you to note that in a step wedge design, you collect for a certain period of time. So you're collecting we're not, in a lot of randomized clinical trials, you collect until you reach a certain sample size, and you want the groups to have a similar sample size. And so we ended up with different numbers between groups because we collect for a certain period of time and not till you hit a certain sample size. So just want to make note of that. Some real-world trial elements included that at least 85 physical therapists and rehabilitation assistants across the country provided the walk and watch protocol to patients. So quite a large number of therapists were involved. Another important real trial element is that new therapists learn the protocol from colleagues that were part of the initial training or from our web resources. And I know we're currently in the midst of updating the web resources. So these were behind a password protected wall because we wanted to keep it within the clinical trial. And we're working on finalizing and updating it and making it even more therapist friendly. And then once it's ready, then we'll release those. So it should be soon. So we did screen a large number of folks, but that was similar between the two phases. And so it's difficult to get completely even numbers, like I said before, because of the step wedge design. But that being said, we did end up with about 306 patients overall, or sorry, 314 overall here. Oh, I've lost my mouse. Oh, there it is. 314 overall. And overall, we were able to use 97% of the data. And so from that standpoint, it was relatively similar between groups. We did have a few less in the walk and watch group, but from a statistical strength standpoint, excuse me, we were still well within a reasonable range. So we had similar baseline characteristics for the two groups. And so in terms of the age, we had between 68 and 67 years old, which is pretty typical for stroke. In Canada, that's generally the average age at which folks get admitted to inpatient rehabilitation. In terms of days from stroke to consent, they're about 27, 28, 29 days after their stroke. So still within that subacute period. I do want to make note of gait speed here. And so on average, we had 0.5 meters per second gait speed, which is representative of someone with about a moderate to severe gait impairment and typical for an inpatient setting, again, in Canada. But with the standard deviation, so the 0.31 and the 0.29 indicated there, That means that a large range of our participants were between 0.2 meters per second and 0.8 meters per second. So 0.2 meters per second is someone who takes 50 seconds to walk 10 meters, like your 10-meter walk test, and they take 50 seconds. So that's someone who's walking really slowly, who is quite impaired with their gait. So we had that, a large number of folks there, and then it also ranged to about 0.8 meters per second. So this is someone who takes 13 seconds to walk 10 meters. So moderate impairment. So again, this is at admission to inpatient rehab. We did have similar adverse events across our groups. And so we had 5 serious adverse events, and we defined that as requiring hospitalization. I do want to note that none of them were related to a PT session. We did have falls, which is again relatively common and similar across our groups. No falls occurred during a PT session in usual care, and one during a session, but the session at that time, they were not doing the walk and watch protocol. They were working on other aspects of PT. So in terms of our 6-minute walk test results at 4 weeks, we had a 43.6 meter difference between the groups. So what this means is that the walk and watch group improved an additional 43.6 or about 44 meters on the 6-minute walk test compared to usual care. So based on the literature, this is a clinically meaningful improvement in walking. So it's we looked at the minimum clinically important difference values reported in the literature, and this is shown to be clinically important and meaningful for patients. So in terms of gait speed, we had improvements of 0.134 meters per second. So the walk and watch group improved an additional 0.134 meters per second on gait speed compared to the usual care group. Again, based on the literature, at least that 0.1 meters per second improvement is a clinically meaningful change in gait speed. So for balance and mobility, we did the short performance physical battery, or short physical performance battery. And this is where you do like a Romberg, semi-tandem, and full tandem stance. And here, again, the walk and watch group improved an additional 1.15 points on the SPPB, and 1 point is a clinically meaningful improvement in balance and mobility. So in terms of quality of life, and so here we did the EQ5D, which is that scale 0 to 100. 0 is the worst imaginable health. 100 is the best imaginable health status, and patients mark on the line where they feel their health is. And the walk and watch group improved clinically meaningful amounts and quality of life over usual care. So pulling this together, statistically and clinically meaningful improvements in walking balance and quality of life were found for individuals who received walk and watch more than usual care. And so we did find that it was successful operating in these real world settings. We had lots of therapists involved delivering the protocol. And what was great is because the protocol went over a few years and therapists were kind of training each other, watching the online videos, reading the manuals and so on, they were able to onboard new therapists as staffing changes happen, which happens fairly frequently in our units. And so, and again, very common with other types of training that you might do, right? A few therapists go to training and then they come back and teach others what they've learned. And so the trial demonstrated the protocol could change the practice of entire rehab units and sustain this over time. And so we're currently really finalizing the 12-month post-stroke results. So we did all of our outcome measures, at baseline when they were done walk and watch, and then we also collected them at 12 months post-stroke to see if there's any sustained benefits. And I can't tell you exactly what we're finding because we're still working on it and things are under review, but I just want to say it looks very promising at this point. It's a little spoiler alert. So I do want to switch gears a little bit. So that's all the statistics, the data. And so if you're frontline therapist and you're just wondering what do other therapists actually say about using walk and watch, because some of our therapists really had to shift how they were doing and thinking about their treatments with their patients. And so I just want to share with you some quotes from the therapists that completed surveys as well as interviews. So I'm sharing a lot of positive things, but there are also some areas of improvement and some criticisms that they have. And I think all of these were fair. So I'm going to share the first group here. We heard that some therapists that they were anxious about pushing their patients, especially around the intensity component. And so here I will provide this first quote here. So I do want to note that the italics and bold are mine. I added that to the quote just to deliver some sort of emphasis here. So at first it was a little nerve-wracking for me to push someone beyond what they would probably be doing before they had their stroke, but I was actually impressed. I think it's more having the confidence that even though all these folks are medically complex and a lot of them are elderly, they can reach these intensities and how much difference it makes in their recovery. As a therapist, I knew that best practice had us looking at dosage and making sure we're hitting therapeutic targets. With a program like the Walk and Watch that helps give you a program to follow and targets to hit, it seems to have made it a little bit easier to translate that knowledge of what is best practice into actual clinical applications. So I think that this speaks to maybe the screening component of the protocol, helping them have that more confidence and helping them reach some of the dosages they're looking for. So we did have components of the interdisciplinary team. So our original training was just with physical therapists. Occupational therapists were sometimes invited depending on how the unit delivered walking practice. Rehab assistants and physical therapy assistants were sometimes invited as well, again, depending on how the unit delivered their walking practice. But some units ended up applying Walk and Watch to other patient groups. So we had one unit reporting that they applied it to incomplete spinal cord, people with multiple sclerosis, and so on, which we thought was really quite interesting. And so another therapist reported that they wanted to do the training more with their outpatient department as well. So for those who maybe started in inpatients, that they could then transition to the outpatient department and still continue to use the Walk and Watch protocol. So some noted that even in the nursing team, that after hours or between sessions, they would hear the nursing say, well, look at your watch, you haven't gotten your steps today, so let's walk to dinner. So some patients were, if the therapist deemed that it was safe for them, they were encouraged to walk outside of therapy as well, because if they were in the trial, they were given their Garmin watch to use. And so then the therapist could say, okay, look at the steps on your watch. I'd like you to hit, so we got to 33,000 steps during therapy. I'd like you to hit 4,000 steps by the end of the day. And then nursing was supportive of that. Some units also had OTs involved. And so from there, they could help engage some of that consistency depending on if there's some therapists that worked on weekends. So I do also want to make note that physicians were, of course, involved, and that the physician would sometimes clear them for that higher intensity walking practice. And that was a really excited component, a good component there. Rehab assistants were often involved in terms of setting up the equipment. So making sure that they had the weighted vest ready, making sure that the patient was wearing their watch. And if they didn't have their watch, we gave the units a few extra watches to use for someone who maybe forgot or lost their watch. So they'd get it ready. Excuse me, I'm getting over a cold, so 'tis the season for all those things. So rehab assistants were involved doing those things that often rehab assistants are really great with. So I do want to speak about timing and staffing because this is something that has come up a lot, especially post-pandemic, healthcare burnout, staff shortages. They at first thought Walk and Watch was an extra thing to do, like an add-on. But once they started realizing that it's not meant to add on, it's meant to replace the typical walking practice, then they realized it wasn't so much extra to do. But however, some sites finished doing the Walk and Watch component of the study, and then they did the interviews after. And they say they're not doing it as much. And some of our sites, the workload has really increased. I think part of it is the pandemic, part of it is just shifting and reporting. And the hospitals are becoming over capacity, in particular in winter months. For us, we have less capacity. Excuse me. Some therapists actually describe staffing as a nightmare. Yeah, I think part of it was COVID, part of it is burnout, staff turnover, and so on. And so some folks described it as being a really challenging thing. So the hardest part for some was the way they structure their sessions. A lot of our sites have patients for an hour a day. Some only had them for 45 minutes a day, some only 30 minutes a day. And trying to get 30 minutes a day for walk and watch when you had to juggle family meetings, home visits, and so on was something that they found was relatively challenging, if not quite impossible for them to do, which I think is quite fair. So some of the things that helped them and what they reported was electronic documentation. So a lot of our charts are electronic, most of them are, but some things are paper-based. So for this particular study, a lot of our research, we give forms to fill out. There was one unit that actually had, excuse me, that actually had updated their electronic documentation. So there was a spot for them to add the number of steps and aerobic minutes that they achieved during the sessions, which just helped if there were staffing changes. So weekend staff versus weekly staff, that they could communicate on the changes that had happened over time related to walk and watch quite easily. So they found that the weights, weighted vests, and so on, that it really helped with increasing the load, help with increasing the heart rate. Some of the family really got on board with this and really supported their loved one with this. So one of the patients bought this family Garmin watches so they could have a little friendly competition with each other. And then there's one that stands out where the family pushed her to walk more, and they were like, "Oh, let's go for a walk before dinner. Let's, while we're talking, why don't we go for a walk?" And the therapist noted that that really helped with achieving some of their goals there. So in terms of onboarding, the therapist reported that they felt comfortable with the online and reading materials, but that having that person there who had already done walk and watch, been comfortable with doing it, having that person there as a resource or a champion of this particular protocol was definitely beneficial. Something else that they thought was really helpful was that as a unit, they decided that they wanted to do walk and watch. And again, having that unit and everyone trying to do something new together felt a little bit better for some of our therapists. We also encourage units to do weekly huddles. So once a week to get together, a little bit like a family meeting or team meeting that where people could discuss any barriers to implementing this. People could help each other. So someone who's done it before could help the more junior person and so on. And that was something that seemed to help as well. Now, technology is also another place where there are a lot of pros and cons. So they enjoyed the use of technology because it allowed the client to have visible data at each session, but they did not appear to calibrate well. I'm sorry. So we did note this with the Garmin watches that I think because they're not made for patients necessarily with higher resting heart rates, maybe take them a little bit longer to increase their heart rate and so on. Therapists did note that it was challenging to use the Garmin watches. The Fitbit was also noted with very, very slow steppers, those below 2.2 meters per second, that they were having trouble with counting the steps. And so they started to get really creative with counting the steps. So they would put the Fitbit on their own ankle, the therapist's ankle, and try to match their steps so that it would count it. But that was definitely a point of frustration for our therapists with the people that walked really slowly. So some people were just generally not comfortable with new technology. And so that felt like a big barrier for them in terms of incorporating this in their clinical practice. So pulling this all together, the summary here is that altogether, therapists and our statistics indicate the walk and watch protocol does seem to work. We did have clinically meaningful improvements in walking endurance, speed, balance, mobility, quality of life. Technology could be challenging at times, So instead of the wrist-based monitor at this point in time, we have been recommending the more standard chest strap heart rate monitor. You can get them relatively inexpensively. And I think often they're now syncing to phones and things like that, which makes it a little bit easier to incorporate. But that might be a more accurate way to measure heart rate. And we recognize the step counter might not be valid for very slow walking patients, and that's something that I think should be addressed in the future. The time to deliver was challenging for therapists who only had 30 minutes allocated to PT sessions. So they did describe the onboarding was effective and support with experienced therapists. So this is the full, I guess the full reference here for you if you'd like to look it up, and I'm happy to take any questions. I'm going to stop sharing my screen because I can't really see you or if you have any questions in the chat box or anything. Oh, there's a message from an AI assistant. All right, any questions? Do your units have 30 minutes or an hour, or what's a typical length of time?
Thanks so much, Dr. Peters. It's just great to watch this. We dream of doing step-wedge randomized trials
Mm,
in the U.S. with these types of interventions. We're well familiar with the designs,
great.
but in behavioral interventions, but just not very well done when it comes to neuro rehab and stroke.
Mm,
So we've been looking to our neighbors up north.
mm,
Um, and really, enjoy the advanced trial work that you all can do up there
mm,
overall. I just wanted to thank you really, because we're very inspired by this
oh, great.
overall, what you're able to do.
Mm.
Um, I think Susan Atwood has a question that I saw, and she's one of our physical therapists. Susan, you want to go ahead?
I think there's something written in the chat. Oh,
Oh,
Susan,
hi,
go ahead. Go
Sue.
ahead. Yeah, hi.
Hi. Thank you so much for your presentation. I truly do love that you emphasize intensity, which is so important with the stroke population, but you actually don't really see that much nowadays. So, and I was wondering, so were you able to follow up with any of the participants and see if there were any lasting effects?
So we did call them every few months after, and so that's not part of the primary outcome, and we haven't looked at those data yet. But after discharge from hospital, we called them at month 6 and 9 and asked them for how their health was. Are they using the technology to track their steps? So we did have a questionnaire that we went through, and then at the 12 month, they did an in-person visit where they did all of our outcome measures again. And then we again asked them the same questionnaire. And so we will be looking at that. I'm really curious to see because there's like a bit of an overlap between we did a physical intervention, but I think we also impacted their behavior because they got a watch and they got to take it home. And if they ended up using that watch while they were at home, like maybe just generally they had an increase in physical activity after the experience with Walk and Watch, we're not sure at this point. Was that answer your question, or did you have more questions?
Oh, yeah, that did. Thank you.
And I think we'll know a little bit more once the 12-month data are published. Again, we'll report on the primary outcomes first, but we're also working on multiple secondary outcome papers. It's a very rich data set, and there's a lot there to disentangle. For example, like in the primary outcomes paper that I reported on today, I didn't go into a lot of detail, but it does look like the effect is different between males and females. And we're trying to figure out why. It's a little bit puzzling. Females didn't do as well as males. And again, that could be really multifactorial. We're working with a statistician to try to model some of these things, but I think some of the things are probably more behavioral, social, cultural, and so on that we didn't necessarily go into in this trial. Right. I think any other questions, Jane Anderson? Oh, you're welcome. I'm glad you could come.
Yeah, many of our colleagues, are thinking about how to implement clinical trials in rehabilitation that are on this call. Um, Probably more, and we're looking at it more in tele and virtual rehabilitation environments. What Janice Ang is doing had a big influence on us in British Columbia. And so, but we were really looking at the step wedge design, so it's just really interesting to see how you carried it out. And I think all of us are really intrigued by if you showing this really can be impactful in patients. I also wonder about scalability. And have you put any thought into that, like how it would be widespreadly implemented?
Yeah, that's a good question. I think one of the things we will do is just make the resources widely available for free. Like Janice saying has done this with some other things that she's developed, like the FAME. And so that's the idea, is that we'll develop resources that end up like that. And again, like FAME, like she likes to get your email address to make kind of track how many people are using it and so on. So that's the goal. And there's a lot of other work that we could do to see different components of walk and watch. I think that's something that we noted is the targets that we gave therapists. They consistently reported to us they were really difficult to achieve. And so that's something that we're working on now is like, do we need to further tailor those targets to make it a little bit more specific to the patients? Do we need different targets for males and females, for example? But with the step wedge design, like I do love it as well. Like I worked on other clinical trials, and from like especially if you're doing some sort of training with staff, I think it's really nice to have that design, because then you can't untrain someone to go back to usual care or to a control group. And so the step wedge design is really nice for that. Then you kind of like do the usual care, deliver some sort of training or intervention, and then see the effect of it after. So I think there's a lot of great things about that. I do think we really needed a statistician that was really well versed in that, to be able to model. There's a big factor of time when you do use a step wedge design. And so that was something that was really tricky, that the statistician, Hubert Wong, he can speak to that for hours, and I can only peripherally speak to that. But that was a very important component.
That's great. I think Jane's got a question.
Yeah, I didn't want to interrupt that awesome, great presentation. I just wanted to share with you, because the reason I like the stepped wedge design is I had a similar project that we did training nurses to do swallowing screening in stroke. And this is when I was in the VA, and we called it B time. And so anyway, it was very much developed around a protocol that had been developed to make sure that nurses were able to screen timely for swallowing. And we did the stepped wedge design with the pre-post tracking of, whether or not they did the screen or not, a yes, no, and that they did all the proper components, because there was a swallow exam that went with it. So long story short, it really was a good way to track changes in the institutions we were in. And because we had a pretty simple metric, it was a lot easier to do. But it is a great design, and it works so well with the kinds of things which you've described. And as Dr. Savage mentioned, we're looking more in the roles of telerehabilitation. And I was asking him, let's do stepped wedge. And he said, well, we need a lot more sites and people to do that. But thank you so much for what you've shared. It's great.
Yeah. But I think you hit on a key element there. Like, if you're doing a step wedge design, if you want to include multi-site, there's something about having simple outcome measures. I mean, simple can be very effective, and maybe simple isn't the right word. Maybe something just more direct,
less complicated.
Yeah.
And easier to identify.
Yeah. And then I think, especially for involving busy frontline clinicians, like it needs to be something that, because there's a lot of complex decision making happening in someone's head, and then you just want to be able to do a quick output of like a quick screen, like you said, a yes or no, I think is really good. With the 6-minute walk test, our primary outcome as part of the screen, that was intentional there too. We knew they were doing it already. It's a good measure for stroke. And so we thought, let's implement it into the screen. And all they had to do is write down the distance on it. That was the only thing they had to do. And then we just gave them a list of potential red flags to clear with the physician. And so beyond that, it was a relatively simple thing for them to fill out. And so I think that was definitely key. And we thought about that a lot with the targets, with the technology that we used. There probably is further opportunity to keep simplifying things in terms of walk and watch, but yeah, I think that's really important, Jane, that you mentioned that. And yeah, the step wedge design is pretty cool. This is my first time using it, and I definitely will try to use it again.
Thank you.
Great. Any other questions or comments?
No, just thank you so much for doing this while you're sick.
Yeah, yeah, it's comes with the territory. I was like not so sick that I need to reschedule, but I was like they might have to put up with me coughing a little bit, but it's virtual, so it's fine.
Okay. I think this is great. Well, thank you so much.
You're welcome. And if anyone has any follow-up questions, feel free to email me. Great.
All right. Wonderful.
Thank you.
Thank you
Thank
so much.
you. Have a good day.
Thank you.
Bye-bye.
Bye.
Bye.